Yeah, I mean, HIF-2 is sort of like the next thing in the treatment of clear cell renal cell carcinoma, right? We had belzutifan, which is approved for patients with VHL syndrome, with this incredible data preventing morbidity and all these unnecessary surgeries. Then we had some very exciting late-line data showing activity of belzutifan in refractory RCC, the phase 3 trial, improved progression-free survival versus everolimus after immunotherapy and TKI. But, just as we have multiple different TKIs, the thought is, can we build upon that success? Are there other options we consider? And so multiple HIF-2 inhibitors have been in development. I think Casdatifan is probably the most promising of those that we have seen so far. So this is an oral agent. And we have phase 1 data with now over 60 patients. And what they really showed is that like 100 milligrams a day seems to be the right dose, looking just at maximum EPO reduction. And we've seen some clinical data, which, for a phase 1 trial is very, very encouraging. Response rates around 30%. I think what's very unique is that progressive disease as best response is actually lower. Now, this is small numbers, but one of the highlights is just that PD as best response seems to be slightly lower than we see with other HIF-2 inhibitors. So this is really exciting data. No new toxicity signals, very much manageable. Having treated patients with this in the clinic, I can tell you that patients enjoy this drug. This is often a break from the side effects we take with TKIs, right? HIF-2 inhibitors are not TKIs. They are a unique class of drugs, sort of very unique side effects, right? So hypoxia happens, and so this is something that you just have to educate the patients on. They may not even feel it, so make sure you're checking pulse ox on a daily basis. And then anemia, and that anemia can generally be managed with maybe transfusions or even use of ESAs with IV iron if needed, and or dose holds and reductions. And so it is a very different toxicity profile, and it really lends itself well to combine with other agents like a TKI. And so as we look towards the future of Casdatifan, I think one of the exciting trials is the PEAK trial, which is going to look at Casdatifan with cabozantinib versus cabozantinib in those patients who have treatment-resistant RCC. And there's other trials ongoing look to incorporate this into the frontline setting as well. That's a great question, right? Who benefits from HIF-2 therapy? So as we look at the current indications right now, it is thought that VHL is upregulated in every single patient with clear cell renal cell carcinoma, independent of any VHL mutation status. So doing genomics, looking for VHL mutation status is actually not something that is required or even recommended as we think about where to use these agents overall. Then the question is, who gets the biggest benefit from this therapy? The thought is potentially maybe some of the more fair risk, maybe more the energetic, they have a better benefit. We have small numbers. It's really hard to make that statement right now. That hasn't really played out yet with belzutifan. We haven't found that great marker. This is the patient. Like what in that, there's over 30% of patients with belzutifan who experience progressive disease best response. We haven't seen what is it about them versus those responders, right? That really makes the difference. I think one of the key things about HIF-2 inhibitors, at least what we know from belzutifan, is that while minority of patients do respond, those that do respond, it can have quite durable responses. And I think that is the hope that if you combine these with TKIs, we could hopefully, allow patients to have these longer and get to some of those durable responses. And there's actually ongoing phase 1 cohort looking at the combination of cabozantinib with Casdatifan in the ARC-20 as the foundation for the upcoming PEAK trial. I think at the end of the day, the goal is really to try to make sure that patients get an effective therapy. And we know that as you go through therapies, as you go advanced lines, less patients get to third line therapy than second line therapy, and certainly fourth and third, right? And so if we can combine drugs together, we hope that they actually are synergistic maybe in some way, but in minimum they're additive. And by doing these drugs together, we're able to get more patients effective therapies. And so I think as we look toward the future of HIF-2, a lot of the trials right now with Casdatifan, looking to combine with novel immunotherapy, or cabozantinib, or even belzutifan, looking to combine with different agents, they're all looking to get into earlier in combination settings. And I think that's possible because of that unique toxicity profile of the HIF-2 inhibitors, that they can be paired with others. And we've seen lots of different combination safety data that shows that this is hopefully going to be a good approach for our patients. This is really exciting. It's another oral HIF-2 agent with favorable toxicity profile with early efficacy signals that lend towards further development at this point in time. I think one of the unique things about it is we've seen other HIF-2 inhibitors that have come and gone, and the Nikkei compound for one was one of those, but it had an exceptionally long half-life, which can make it sometimes challenging to manage. So I think as you look at Casdatifan, it is definitely appealing. Has that right balance of half-life and toxicities that make it a good one to look forward to.